Welcome back at the Centre for Economic Policy Research. We bring you the most important new research on the economic impact of COVID-19. My name is Tim Phillips. How many people have been infected with COVID-19? Well, so far the estimates of the proportion of asymptomatic infections are all over the place. And the randomised mass testing that would provide the certainty that we really need is a long way off. Meanwhile, we have to make policy choices based on this incomplete data that are literally a matter of life and death. Well, David Miles of Imperial College and his co-authors have estimated the asymptomatic rate of infection using a non-random sample of people tested in the UK and other countries. And he joins me today to talk about a surprising result. Well, David, welcome back.
Hello.
Now, put simply, what is the benefit of knowing the number, the proportion of asymptomatic infections in the population?
Well, I think what one really wants to know is what proportion of the population right now are susceptible to getting the virus and what proportion are not susceptible. And one way somebody could become no longer susceptible is to have had the virus, built up a degree of immunity, recovered, and then you're not susceptible to get it again. We're not quite sure for how long you may be no longer susceptible. Hopefully it's for a long period of time. So knowing how many people have had the virus and recovered is important for understanding how infections may pick up again and deaths may pick up again if you rapidly ease restrictions. I should say there are other reasons that many researchers have put forward for being non-susceptible to the virus beyond simply having been infected in the past. And that's one of the reasons why there's a huge disagreement, or rather, I should say, uncertainty about what proportion of the population may no longer be susceptible to the virus.
Yes, I characterize this disagreement, uncertainty, as the estimates being all over the place. Can you give me a little bit more of a rigorous analysis of that? What do they range between?
Yes. Well, there was a study conducted, I mean, quite early on in the history of this virus by the team around Professor Gupta in Oxford, who used death data in the UK and argued that it was likely, even as early as, I think it was the middle of March, that perhaps 60% or so of the population in the UK had built up immunity because they'd had the infection. And as I say, that was based on looking at the trajectory of deaths and how it was beginning to level off even way back then. There's also some work done by, much more recently, by Carl Friston at University College, professor statistics applied to medical issues quite often at University College London, and also Michael Levitt from Stanford University, who put the proportion of people who are now not susceptible to the virus in many countries, including the UK, as high as 70–80%. On the other hand, some of my colleagues at Imperial, the group around Professor Neil Ferguson, would argue, I think, that the number of people who have been infected in the UK may be as low as somewhere 7–8%, probably less than 10%, and the implication being that 90% of the population are still in the susceptible group. So, you really have a very big range here, from 90% of people might be susceptible to 20% of people are susceptible.
And a much bigger range than we're used to in modelling these things. Now,
absolutely. It really is a huge range. Correct.
Now, to model this, you've taken the basic model that's guiding so much of the research.
Yes.
What assumptions do you make on the data that you're putting into this model?
Yes. Okay. So as you say, Tim, we've used the SIR, the susceptible, infected, recovered model, widely used by epidemiologists. We make the assumption that in most countries, until relatively recently, until say the beginning of May, overwhelmingly the people that were being tested were those that had symptoms, and quite often quite severe symptoms. I mean, in the UK, until we get into May, I think, overwhelmingly people who were tested were people who had turned up at hospitals clearly ill, very clearly had symptoms. And we assume that, first of all, undeniably, the sample of people who were being tested, from whom a subsample then were recognized as having had the infection, were very clearly not a random sample of the population. This did not tell you much about what proportion of the population of the UK had been infected, because it's pretty clear that some people get infected with very few symptoms. So we assume that until you get into May, until you get to the end of April, pretty much overwhelmingly in the UK and other countries, the only people being tested were people who had significant and obvious symptoms. We also assume that, imagine that for every person who's infected and has clear symptoms, there are an unknown number, X, who have the infection but don't have significant symptoms. And our strategy was to try and estimate from the data on how many people had had symptoms and been tested positive, how large would X need to be to best explain the trajectory of the number of people who were being tested and shown to be positive. So we have an unknown variable, X. X is how many people with no symptoms are there who've been infected for every person that has symptoms and has been tested positive. And we try and estimate what X might be by asking the question, how big would X need to be to best fit the actual recorded data on the number of people who are showing up with symptoms and testing positive?
And how confident are you of that recorded data that you're being used to calibrate this?
Well, I'm not entirely confident, inevitably. I think measurement issues just bedevil this whole issue about how the virus is developing. I think it's likely, no more than this, that people who had severe symptoms did end up in hospitals largely, or they were very ill in care homes. And many of those, certainly the people that went to hospitals, were tested. So I think you've probably got a relatively high proportion of the people who had very clear symptoms being tested. I think it's also, one can be fairly confident that those people who had very few symptoms, or indeed no symptoms, were not being tested until more recently in the UK, when the number of people tested has increased very rapidly. And so now we have closer to, it's still not quite a random sample of the population being tested, but at least closer to that. But that's really only since probably May.
And so, what does your model tell you about, for the UK, say, about the proportion of asymptomatic infections, the number of people that have already had COVID-19?
Well, it looked pretty likely from our results that there were a large number of people who were asymptomatic for every person that very clearly was symptomatic. It's difficult to tie down that number. In fact, it's the number X I was talking about earlier. It's very difficult to be very precise about what that number is. We think our estimates suggest it is very unlikely to be less than 10. In other words, for every one person who was symptomatic, got tested, had the disease, the virus, there were likely to be 10, but perhaps more than 10, perhaps even significantly more than 10, who had had the virus, but at that time were not showing significant symptoms. 10 was a kind of lower end of the range of plausible estimates we came up with for the UK. At the top end were numbers much, much higher than that, as high as 150, 200. If one were confident about being at the top of that range, the 150, 200 end, then the implication would be that a very substantial proportion of the population have already had the virus and recovered, thankfully. as many as maybe 40 or 50%. At the lower end, if there were only 10 or so people with no symptoms for every person that had symptoms, then we'd be at a much lower level, of course, and maybe only the 10% or so of the population would have had the virus. That's not unhelpful, even if the answer is only 10%. That still does bring down the famous reproduction number somewhat, but obviously it's nowhere near so-called herd immunity. So we were not arguing that our results show the UK is already at herd immunity. That's at one end of the spectrum. But we were arguing that there was a substantial proportion of the population likely to have had the infection, and perhaps somewhat more than the rather limited evidence based on other kinds of tests of a sample of the population for how many people had had the virus.
You've taken this, you've used data from other countries as well, haven't you, to estimate what's going on there as well. Did you come out with similar results?
Surprisingly similar, actually. In fact, the point estimate, if you will, for this number X and the uncertainty around it looked remarkably similar for other countries, for Italy, Spain. We looked at the US as well, France. It was consistently the case that the central estimate anyway suggested there were a very large number of asymptomatic for every person who was symptomatic but had the virus.
Now,
I should say,
yes,
the direct testing of relatively small samples in a few countries of the population for how many people had signs of having built up immunity by having antibodies, so-called serology tests, are putting the proportion of the population that had been infected lower than our estimates would imply. That's the kind of 5 to 10% level, as opposed to numbers that we think are plausibly higher than that. So it may be that our estimates are not central estimates, or it may be, as other researchers have suggested, that those tests for antibodies, that serology testing, may not be picking up people who have had a low viral load. There's a whole other argument that, and this is really the argument of Carl Friston at University College in London, and I think also Michael Levitt, that there are potentially a much larger group of people who have not had the infection but are naturally immune anyway. They are not in the susceptible group. And in fact, Carl Friston believes that proportion is very high.
Now, even with our super fast publication process, then clearly what we're learning at the moment very quickly goes out of date. There's new data coming in all the time. Can you continue to improve your estimates?
One of the assumptions we made, which I think was realistic, was that up until probably the end of April, in most of these countries, overwhelmingly the people being tested were those people that had symptoms. After the end of April, the story changes. The number of people being tested grows very rapidly, certainly in the UK. And it's no longer the case, more recently, that people who are tested all have significant symptoms. And that's an important identifying assumption for the particular empirical strategy we followed. So the more recent data on how many people are testing positive actually means something different from what it meant on the pre-May data. Mm-hmm. So I think ours was a study that really can only draw on data from that earlier period. Of course, there are other things to be learned through different other techniques. There's a whole load of researchers using sort of time series statistical modeling techniques on death data. And I mentioned some of the names earlier, Carl Friston, Michael Levitt, who've used that data. I think have stepped outside of the so-called SIR model, which I relied on in my work. And they're actually coming up with very high proportions of the population that they believe are already not susceptible to the disease. The implication of that is, as Michael Levitt has argued very strongly, that actually easing the restrictions should be done, immediately.
Yes, everyone's focusing now on this sort of second wave of infections and the easing of the lockdown. Does the work that you've done give you any opinion, intuition about what's likely to happen as we ease the lockdown or the scale of the second wave?
Yes, it does. In a sense, for the obvious reasons that the more evidence you have that the susceptible proportion of the population may be lower than the 90% number that some people believe, simply based on serology testing of how many people have had the virus. Maybe you think that number is only 10%, therefore 90% are susceptible. If you believe that there's significant chance that that number is significantly higher, the number being the people who are not susceptible, then rationally one would think that the risks of easing restrictions are that much lower, given that we know the costs of the restrictions, certainly the sort of severe kind of lockdown that we've been in the UK, given that one knows that the cost of that is very, very high. If one believes the risks of costs on the other side from easing the restrictions is lower, then logically you wouldn't think that it pushes you towards thinking you should ease restrictions more quickly.
Well, it's very interesting. We will shortly find out exactly where your estimates were on the spectrum. Thank you very much, David.
Thank you, Tim.
Now, the paper we've been talking about in issue 16 of COVID Economics, it is called Assessing the Spread of the Novel Coronavirus in the Absence of Mass Testing, and the authors are Oscar Dimdor-Miles and David Miles. Now, keep in touch with the COVID-19 coverage at VoxEU. There's tons of it, and there's more every time you look. So from David, myself, and everyone else at the CEPR, goodbye for now, and stay positive by staying negative.